Welcome to the Centre for Anaesthesia student podcast series. In this podcast, we'll be discussing some of the factors involved in giving a general anaesthetic to a patient. After listening to this podcast, you should have a framework of what you will see during a routine general anaesthetic list in theatres. When we talk about general anaesthesia in hospital for elective surgery, we usually mean a reversible state of unconsciousness, which allows a potentially painful procedure to take place. We use a combination of drugs to achieve this. The precise mechanism of action of the anaesthetic drugs is not well understood, and this is partly a reflection of how poorly we understand what defines consciousness. However, you can be reassured that we have a very good knowledge of how to use these drugs in our clinical practice. We see all of our patients before their anaesthetic in a pre-assessment clinic. This allows us to get background information about their medical history and is an important time for answering any questions or providing reassurance about the anaesthetic. Depending on the patient's condition, we may need to modify the anaesthetic that we give or occasionally postpone the procedure to optimise a medical problem. When the patient is in the anaesthetic room, we perform some safety checks before we start the anaesthetic. Once the patient is asleep, it is not possible to confirm their identity, check that the consent is valid, that the patient is starved, or if they have any allergies, so it's vital to do this before we give any drugs. Once this is done, we check and attach our monitoring equipment that we used whilst the patient is anaesthetised. We're quite specific about the equipment that we use to do this, and if the equipment is unavailable or not working, then we won't start the anaesthetic. As a minimum, we attach ECG, an oxygen saturation probe, a non-invasive blood pressure cuff, and make sure that we have a way of measuring the gases that go to and from the patient. In an ideal anaesthetic, what we want to achieve is an asleep patient who has excellent pain relief whilst maintaining perfect operating conditions for the surgeon. This is sometimes referred to as the triad of anaesthesia: unconsciousness, analgesia, and muscle relaxation. Most of the drugs we use in anaesthesia fit into one of these categories. If it doesn't fit, then it's usually a medication that we're giving to counteract the side effects of our anaesthetic drugs. An example of this would be an antiemetic. Drugs that induce sleep are known as hypnotics, and the ones used in anaesthesia are usually given intravenously or by inhalation. Examples of IV agents include propofol and thiopentone. You'll almost certainly see propofol being used, and it's clearly marked out by its white colour. Isoflurane and sevoflurane are examples of inhalational hypnotic drugs. These drugs are converted from their liquid phase by the vaporizers on the anaesthetic machine to a gas phase that can then be delivered at a precise concentration via a breathing circuit to the patient. Even though the patient is asleep, the body will still respond to noxious stimuli, so we start giving analgesia before the surgical procedure starts. We normally follow the WHO analgesic ladder. The amount of analgesia required depends on the type of surgery and how much tissue damage takes place. It is common to use a combination of analgesic drugs, for example, paracetamol, a non-steroidal anti-inflammatory, and some strong opioid. Muscle relaxants block transmission at the neuromuscular junction and cause relaxation of skeletal muscle. This stops the resting tone in the muscle from interfering with the surgical procedure or the intubation and ventilation of the patient. It's not used for every procedure, but you'll commonly see them used during cases that are intubated or during a laparotomy. Examples include atracurium and suxamethonium. Taking the patient from being awake to a surgical plane of anaesthesia is called the induction. Most commonly, you'll see this being done as an intravenous induction, with drugs given through a cannula. We can also induce sleep by breathing a gas. This is called an inhalational induction and is commonly done in children or in people with really difficult IV access. There are pros and cons to both techniques, but ultimately, both are safe in trained hands. Once anaesthetised, the patient's airway reflexes will be diminished, and so the airway will need to be managed. This may take the form of an endotracheal tube, a laryngeal mask airway, or by maintaining the airway with a face mask. After the induction comes the maintenance phase of anaesthesia. Again, this can be achieved with either intravenous agents given as an infusion or with an inhalational agent. Mostly, you'll see inhalational agents used at this stage. As a general rule, all the hypnotic drugs cause some degree of cardiorespiratory depression. During the procedure, we must ensure that enough anaesthesia is given to ensure that the patient remains unconscious, but not too much so that we struggle to maintain an adequate blood pressure. During the maintenance phase, we also begin to titrate some analgesia to help prevent the stress response to surgery and ensure that the patient is comfortable when the procedure is finished. Returning from anaesthesia to being conscious is called the emergence phase of an anaesthetic. We achieve this by either ventilating out the inhalational agents or allowing the intravenous agent to be eliminated from the blood. It's a potentially dangerous time from a cardiorespiratory point of view. Tachycardia and hypertension at extubation can lead to myocardial ischemia or stroke. In the lighter stages of anaesthesia, we also see the return of primitive airway reflexes such as laryngospasm, which can lead to airway obstruction, if not recognised and treated promptly. Once awake, the patient spends some time in recovery to allow the residual effects of the anaesthetic to wear off and ensure that their pain is well controlled. Our duty of care extends into the post-operative phase, so it's important to make sure that appropriate analgesia, fluids, antibiotics and DVT prophylaxis are prescribed. Depending on the procedure or the patient's comorbidities, they may need to spend some time in ITU or HDU post-operatively. Thanks for downloading and listening to our podcasts. If you have any questions, comments, or would like to suggest a topic for a future podcast, then please check our website at www.ucl.ac.uk/anaesthesia.